Hello, everyone. Thanks for joining us for this session on automation and radiation therapy. The title of this session is Automation Bazaar, Clinical Tools at Your Fingertips. My name is Tyler Blackwell. I'm a medical physicist with Radformation, and I want to thank the organizers for inviting me to speak on automation in the clinic. But this isn't just any old talk. This is a virtual edition talk on automation and radiation therapy, which is very meta in my opinion. I'm very proud to be part of the first ever virtual spring clinical meeting. And the one benefit to me as a presenter in a virtual environment is that I won't be able to notice when no one laughs at my awful jokes. I'm really happy that AAPM was willing to give the virtual meeting a shot, and I hope it's been productive for everyone. I applaud the staff and volunteers that have been working very hard to pull this off. For disclosures, I am a Radformation employee. Yeah, so I put this slide up for two reasons. First, just a few weeks ago, I attended the Winter Institute of Medical Physics in Breckenridge, and I really enjoyed the intro slides that give a glimpse into the presenter as a human being. Second, this meeting's a virtual one, so hopefully, with a little bit of background, you know just a little bit more about me before I get started. And so, maybe you don't recognize my name, but you've seen me around. So a little bit about me. I just recently joined Radformation last year. But prior to that, I worked with Northwest Medical Physics Center over here in Western Washington for 10 years in the clinic. I'm a father to Watson, who's 4.5, and Atlas, my daughter, who's 2. And in my spare time, I like to invest in real estate. You can see there's a picture of a house that my wife and I rehabbed and sold in 2019. I'm a basketball card collector, so gosh, putting that on there, I'm really letting you into a little bit of my inner nerd. But I've got some good ones over the years. I'm a gardener, and then I like hiking and anything outdoors and active. So the bottom right picture there is one of Mount Rainier from Reflection Lakes in the national park. Here is some contact information for me. I work with Radformation, like I mentioned, so I spend some time on the blog, and we've been putting some good time into the blog. There are some really great fun interviews with physicists on our Focal Spot feature, and interesting pieces on relevant topics within the field. You can also find me on social media. I'm on LinkedIn and Twitter, so please add me. My handle for Twitter is there. The conversation on Twitter is actually really great, and I think it's a great platform, very productive and collaborative. It's a great way to get a feel of what's going on in real time. It's a good spot to get the latest in research or updates in the field. So check it out. So the talk, I'm going to try and split into two different pieces. The first of which is sort of a motivation for why automation is happening right now and why we're going to continue to see more radiation therapy automation in the future. And then we'll look at clinical automation solutions that are ready right now to plug and play into your clinic to automate different processes in the workflow. Automation is creating more efficient ways to do what we all as clinicians want: better, safer, faster, and less expensive treatment solutions for patients. So I think it's worth saying that while automation will be more commonplace as time goes on, to a large degree it's already here. We use it all the time. If anyone uses Variant ARIA or has used ChartQA, that's a program that automatically tells you when a patient chart's ready for physics review. You can automate beams on your clinic, and IGRT fractions are now treated in a 10-minute window. So that whole treat workflow has been automated and optimized so that we can do more with less time. And now we're seeing we have more access to data, and we can leverage the power of AI and machine learning to continue to push the boundaries of automation. And automation is just going to continue to improve clinical radiation oncology because of a number of factors, including error reduction. I mean, we know that automating things removes a human error element, so we can prevent errors from happening or reduce them. And then automation allows us to improve the quality of care, which is really what we're all in it for. We want the best patient outcomes, and we want our patients to live longer, healthier lives. And there's just no doubt about it that economics plays a role in this as well. We know that internal and external pressures are continually demanding more efficient workflows. To err is human. We're all aware that errors occur in radiation therapy departments just like anywhere else. And we all understand this. It's something we've been hearing a lot about. And so we have these checks in place in our departments to try to prevent the errors. We have checklists for dosimetrists and physicists, even for therapists. We have initial plan checks. We have weekly plan checks, final plan checks. But when it comes to the initials, doggone it, if those checks aren't ineffective much of the time. A previous colleague of mine, Olga, did some nice research with her colleagues at the University of Washington a few years ago, and well, instilled in me some insecurities about the quality of my work. But what she found was that out of 125 critical or near miss events that originated prior to physics chart review and could have been detected by physics chart review, only 38%, so less than 40% were actually detected. In their conclusions, the suggestions for improvement that they had included the automation of specific physics checks performed during the pre-treatment physics plan review and overall the standardization of the review process. So, they concluded that automation does play a role in preventing these errors. But are we really that bad? I know most of my physics buddies feel smart and act smart most of the time. So we have to blame it on something or someone else, right? It's human nature. It turns out we have a scapegoat. It's our workload. Well, it's not going to bail us out completely, but the study in 2012 by Mazur et al. Did look at workload and stressors in radiation oncology and found a couple things. Turns out physicists have the most demanding workload in radiation oncology. It came as a surprise to me, but it turns out that when they looked at stressors like interruptions, time factors, technical factors, how difficult our workload is, including teamwork, that we do have the hardest workloads. I mean, we get interrupted all the time, and you think, we have to pay such close attention to detail when we're doing our physics reviews or attending to our quality assurance for patient-specific needs or for the machines. But interruptions, they just happen, right? It's part of the clinical workflow. So what they also found was that there's a positive association between workload and the frequency of reported radiation therapy incidents. Makes sense to me. This fourth one is not associated with the study, but it's interesting and it points to the problem of physics workload. The 2018 professional survey found that 4 out of 10 physicists work 50 or more hours per week. So a lot of those are in the university, college, hospital settings. But regardless, that's still 40% of our field of physicists that spend a lot of time working that probably contributes to this workload issue. I'm hoping most of you have seen this pyramid before, but in case you haven't, this is a representation of the techniques we can implement in radiation oncology or medicine in general to help in prevention of errors. And so you can see there's a number of different implementations from education and training to rules and policies, all the way to forcing functions at the top. And there's a gradient here. On the top, you see, software-driven automation, computerization, different things that are more system-oriented. It turns out they're more effective. And then the things we spend a lot of time on in the clinic, rules, policies, and procedures, anything human-oriented turns out to be less effective in preventing errors from occurring in medicine. So despite the fact that one method may be superior than the other, doesn't mean we can't use all of our tools. So even though policies and procedures can be the bane for most of us, they still can be helpful. Safety and quality improvement is a phrase we're all comfortable with now. It's become a thing of culture within our departments, and that's great. One of the biggest reasons for that is Astro's safety is no accident document. It was originally published in 2012, but had an update in 2019, just last year, to update the different task groups and medical physics practice guidelines that have come to bear in the last decade. So, you know, that the recommendations from the society level really motivates us to reduce errors. But so does accreditation. I know at the clinic I was at last, we were pushing toward accreditation, and we put a lot of work into making our clinic better, right? Into reducing these errors and to improving plan quality, and to making sure we had all of our documentation ready to go. And then billing. So the future of billing is bundled payments. Okay, it's gonna happen, and so that is gonna incentivize more efficient treatment. TG 275 was published in January this year, so very recently. And this task group surveyed clinics nationwide to get a feel of what was included in their chart review processes. And looking over that data, they used failure mode effects analysis to come up with recommendations for chart review for initial plan checks and weeklies and end of treatment plan checks too. I'll say it's a really great resource to review and to get an idea of how your chart review process compares with AAPM recommendations based on their TG 100 methodology. I know I submitted data for this when it was called a number of years ago, and I'm glad to see this task group come to fruition so that we can improve our chart checks. This checklist was recommended by TG275 based on their FMEA and includes checks that have a high risk priority number and are worth checking. Uh, a lot of these checks are things that you're probably familiar with: tolerance table, potential for collision, uh, field ID, course ID. So a lot of these things are fairly simple and easy to check. Others are more difficult and take a little bit more time. But I think the point here is that there are dozens of things that we have to remind ourselves of each time we do an initial plan check. And for me, I think this works for most people too, is that the smaller the checklist, the more effective it is. So something like this tends to overwhelm. Um, and so when I asked Eric Ford about this, who is the primary author of TG275, he said basically what I'm trying to tell all you right now is, and that's that we can leverage the power of software and automation, of these different tools that are coming out to help us with these things, because things like course ID or field ID can be really easy checks in terms of automating, and can allow you to focus on the registration of the fusion of the patient instead, something that requires human intervention and clinical experience. So here are a couple of quotes from TG275 that I found pretty compelling. Automated processes would more efficiently and effectively check specific components of the chart check, such as planning target volume and organ at risk margins. Therefore, physicists would have more time to devote to other aspects of the chart check that do not lend themselves to automation, such as overall plan quality, review of prior treatment, laterality confirmation, or issues related to image guidance. And also, while automation cannot replace human decision making in various clinical situations, it can improve efficiency and effectiveness and allow physicists to focus more attention on the review tasks that do require human judgment. Economics is absolutely affecting our field. There's no doubt about it that we feel pressures from within our departments and from outside as well. Globally, the number of treatment fractions is predicted to increase a total of 71% from 2012 to 2035. Certainly, automation plays a role in making that happen domestically, but the developing world also relies very heavily on the work of the US and Europe to lead and innovate clinically. So there's really a global need that drives our efficient processes. Reducing the time to treat is another important driver of automation. We see patients do worse overall as the time to treat increases. Published last year, an observational study reported that after reviewing nearly 3.7 million patient records, the Cleveland Clinic researchers have shown that newly diagnosed cancer patients, those that have stage 1 cancer, are having to wait longer to begin treatment, a delay that is associated with substantially increased risk of death. So 5-year survival drops between 1 and 3% per week in curative settings like early stage breast, lung, or pancreatic cancer. So you can see in the graph that non-small cell lung cancer drops, the 5-year survival drops from 56% to 43% in cohorts where the time to treat is either less than 6 weeks or greater than 6 weeks. And the same for pancreatic cancer is true, that there's this drop in survival from 38% to 29%. And Dr. Brian Bolwell sums this up as well with this complimentary quote. So, in addition to its impact on outcomes, delayed treatment to time initiation can cause unnecessary stress and anxiety for patients. It appears that our reimbursement landscape may be evolving in radiation oncology from the fee per service model, in which every code associated with a particular treatment, from the simulation to the CBCT, they're all reimbursed separately right now. And I think we're heading to a bundled model that provides a single payment for a given patient's diagnosis. This is something that's called an episode-based reimbursement model. The goal behind it is to simplify the reimbursement process and provide savings to patients and improve the quality in the process. CMS, the Centers for Medicaid and Medicare, has this model called ROAPM, the Radiation Oncology Alternative Payment Model. And to test this model's efficacy, they're going to provide bundled payments for 17 different disease sites you see here with their proposed reimbursement rates. CMS actually intended for this model to be on trial right now, but there was some feedback from professional societies, and so they pushed back the implementation for now. But essentially, during this testing phase, a random selection of 40% of radiation clinics nationwide, with a few exceptions, will be sites will be required to participate in the model. These selected trial sites will be reimbursed the rate here in a site-neutral manner, meaning freestanding hospitals receive the same as hospital-based centers. Again, these are all attempts to simplify. But it's interesting to note that, first of all, the rates here are derived from 2017 national averages, and I'll say that these rates will have increased in the last 3 years. But then also, in order to provide the savings, CMS will just take a certain amount off the top. It turns out that CMS is going to withhold 4% of the professional component, 5% of the technical component to provide those savings. So CMS is making an attempt to reduce the cost and increase value, and that's to their credit. As I interpret it, it's asking us to do more from a quality perspective, but for slightly less reimbursement. Of course, results may vary depending on if your department is being reimbursed on the high side or on the low side prior to implementation. But I think you all get the point that we have to be more efficient and continue to improve patient safety and overall treatment quality. Automation is low-hanging fruit in this regard, as it can often scale and has the ability to process enormous amounts of data. So now we'll hit the part of the talk about integrating automation in the clinical settings. So how do we get there? There are a number of vendor solutions out there right now that allow you to automate your clinic today. By no means is the following collection of vendor solutions a complete one. If I did leave someone out, it wasn't intentional. I only have so much time and can just show you some pieces of the workflow, but there are solutions for automation all the way from contouring or even in sim, right? There's Siemens has a CT simulator now that has a software package for contouring as well. So there's automation solutions at every step along the way. So you can see I don't have QA as a subject here, although there are a number of products that fall into that category as well. And If you do want any more information on any of these products, I recommend just reaching out to the vendor partners shown here to schedule a time to chat, given that the virtual meeting doesn't have a vendor presence this year. I want to introduce ARIA Care Paths here, and while this doesn't fit into any of the categories of automation that I presented in the earlier slide, it's worth pointing out here. CarePath is an automated workflow tool in ARIA that allows departments to link different tasks in a workflow and create dependencies on one another. This has been out since version 11, I think, and based on what I've gathered, not everyone's really using it to its full capacity. I've been to some clinics that have it but don't use it. And while that's fine, I love what I love about CarePath is that it's integrated into ARIA, and when one task is completed, the workflow continues with the next task, and so on. So if simulation is complete, another task pops up for the dosimetrist, say, to finish the contours, and when that dosimetrist completes his task, the workflow continues by going to the physician to review those contours and to add GTVs, etc. So everyone knows that if they're doing their part, completing their tasks, that the workflow chain is going to continue. And of course, custom templates can be generated for different workflows for IMRT, VMAT, 3D planning, SRS, and SBRT. And you can add whatever tasks are helpful. In the clinic, we had OSLD tasks for when the physicist was going to go to the machine to make an in vivo measurement, task for special medical physics reports, you name it. So ask your favorite, or heck, ask your least favorite dosimetrist what they think about contouring and how long it takes them. For some, there may be some mild contentment with contouring because it could be like an adult coloring book in a way. But for others, it's very tedious. It's a manual process that can be very time consuming. Auto contouring opens the door for faster start times for patients, or faster mid treatment planning. So MIM Maestro is a product that offers atlas-based segmentation algorithms, and they have these pre-made atlases that they provide with the product, so that you can get started with auto contouring at install. Of course, as you get more used to it, maybe you like your contours a different way. You can customize those based on your previous patient contours. And they've got this contour copilot that helps with slice-to-slice deformation using the underlying image while you're editing contours. And there was a study done a few years back with Horvath et al. That reported a time savings of almost 70% using auto segmentation for liver. So, MIM Maestro and auto contouring can really help to streamline the contouring workflow. Mirata Medical has a product called DLC Expert that employs deep learning algorithms for critical structures, using AI auto contouring as an approach to an atlas-based method. And that means you can bring AI into the clinic and use it at any point, right? It's available 24/7, and they have this zero-click automation, which in theory pulls any images you have in your CT scanner folder, pulls them right in, does all the auto contouring, and spits them back out, so that uh, you can use your native treatment planning system and the contouring tools that you're familiar with to touch them up, and you're ready to go with the planning. I think it's important to mention that with any auto contouring solution, there is a need to review all the contours, because the AI can be a little tricky in some cases with any product. But the point is that these do save time in the end and allow you to spend time to fine tune things or to expedite the patient time to treat period. In the last several years, a number of vendors have offered solutions for streamlining treatment planning workflows. Um, so we'll go over some treatment planning solutions from RayStation, from Radformation, Philips, and Varian. But how does automating treatment planning serve departments? So for one, I think it definitely saves clinicians time. You could look at studies for each one of these products and find references showing that there are time savings for each one of them. That allows us to devote more resources to other tasks. So we all know we have task group recommendations to catch up on or projects to finish. Um, but also automating these portions of treatment planning can reduce inter-planner variability. So the plan quality is more consistent regardless of experience level. So RayStation has a really wonderful IMRT breast planning tool. It's pretty easy to use. You just during simulation, a wire is placed around the breast tissue or along the chest wall, together with four markers denoting the superior, inferior, lateral, and the medial margins. And then from there, automatic contouring of target and risk organs can happen. And then RayStation actually sets beams up and can optimize the gantry and collimator angles. So yeah, the breast planning can be pretty well automated for IMRT. What I think is cool about this is that with that power of scripting, this procedure can be done for a large number of cases all at once. If you have a study that you need to complete or whatever. PlayStation always also has this neat Plan Explorer workspace that runs multiple different plans with different techniques and energies. So if you have IMRT, VMAT, 3D, and different energies, you have flattening filter free, you have flattened beams. It takes all of the clinic's resources into consideration and creates a number of different plans. So this allows you to explore um, different techniques that would have been too time consuming to consider in the everyday routine. And you can filter by the most desired treatment features and the best plan. So along those same lines, RayStation also has their fallback planning idea where you can plan your IMRT or your VMAT for a particular machine, and RayStation automatically creates these other plans according to your department's equipment. So you can swap in case of a down LINAC or other emergency. Um, the planning for these clinical hiccups doesn't have to be rushed or stressful. So we all know that rushing to finish tasks is a big cause of error. EasyFluence is a product from Adformation that automates 3D planning for Eclipse users, leveraging that Eclipse scripting API I was talking about earlier. So you launch this just from the scripts within Eclipse. So it's kind of nice to have that right in Eclipse. But using EasyFluence, you can create any 3D plan in as easy as just a few clicks, including field and field or ecomp plans, which can be quite time consuming. So you just set up an open field fluence. You set up blocks and calculate the dose, and then the software does the rest, respecting your hotspot or coverage goals, creating a number of plans in the process, and there's a lot of customization tools to adjust the plan to your liking. The University of California at San Diego was able to use EasyFluence to evaluate a completely new workflow, where instead of a back and forth process from dosimetrist to physician with the reviewing and editing of the plan over multiple days, the physician now just chooses and approves a plan with the dosimetrist in one step. Radformation just released a new version of EasyFluence that includes an IMRT to 3D converter. Insurance companies often deny IMRT claims and require further documentation in the form of a 3D plan to show that that IMRT or VMAT plan was superior in some way to a 3D plan. And that can be a little frustrating sometimes. We know often as clinicians that that IMRT plan is better, but we still have to provide the 3D plan. But it doesn't have to be difficult. So this new IMRT to 3D converter with EasyFluence takes your ISO and automatically creates a 3D plan with a beam arrangement that makes sense to you. You can change the energies, couch, collimator, gantry angles, and mess around as well with the MLC for margins as well. So you can very easily transform this painful work into easy documentation for the insurance. Previously called auto planning, personal planning is the latest version of automated treatment planning for Pinnacle. So the latest version, according to Pinnacle, according to Philips rather, is 70% faster and integrates easily with Sun Nuclear's Plan IQ that we'll see a little bit later. Scorecards are also included with Pinnacle and don't require auto planning, and those scorecards can be really great for evaluating plans after the fact. And you can evaluate them based on a number of templates for IMRT or SmartArc. 3D conformal, etc. But this personalized planning I've heard great things about it, and you can set up custom templates for optimization objectives, the prescription and the technique, and then the optimizer actually runs, evaluates, and continues to fine tune the plan. And then you can use those scorecards, like I said, to provide that at a glance evaluation of the goals. Variant Rapid Plan is a knowledge-based treatment planning solution that allows you to create models based on previous plans that you've created in your clinic or from other clinics. And so you create these models, and then for future patients, you have an idea of what's realistic in terms of expectations for a particular patient that comes in with the OARs and the target that you present. And so it'll give you this DVH estimation tool to show what dose coverage and organ sparing is possible. And this is really great because it reduces the variability and the inconsistencies among treatment planners, and you can really reduce or eliminate the time consuming plan iterations. I want to give a shout out to the Variant Marketplace, where you can find some really great rapid plan models from UCSD and Miami, all for free. So you can use and leverage the expertise from clinics worldwide in your community clinic. So we've created the plan. Now we have to check it and report it. We all know plan evaluation reporting can be on the time consuming side. So hopefully automation can help us with this to free us up for some time for deeper evaluation of the plan. And it can help us reduce the plan check burden, which can be large. Now, I didn't mention this before, but TG 275 reported that 25% of their survey takers reported performing more than 6 initial plans in a day on average. So do you think that the quality of charts 5, 6, 7, and 8 have the same attention to detail than the first or the second plan check? And that was a rhetorical question, since I guess you're not there to nod in agreement. So I have this story about an SRS case in which, with all gathered around, ready to get started, patients on the table. It's a frameless patient, thankfully, but the plan won't load up. And there's no problems with the QA, according to the physics department. It was done in QA mode. Live support calls while the patient was on the table. Couldn't resolve the problem immediately, and unfortunately, the patient was sent home. Turns out, after some digging, some more investigation with the vendor, that it was a tolerance table that wasn't selected for this plan. And of course, everyone's feeling dumb. This is something that's routinely checked, but among the myriad of other things being checked, this one thing just was overlooked. Well, ClearCheck would have caught this. ClearCheck is an automated plan check reporting tool from Radformation that helps clinics with these things that can be potentially overlooked. ClearCheck has templates to analyze dose constraints, to evaluate structures, run plan and collision checks, and even run a report with all that information. So here's an example of the plan check report. You can see that that ClearCheck has nice structure checks, margin checks, and conventional plan checks. So for structures checks, you can make sure that there's no stray pixels or slice gaps. And then margin checks shows if you're intending to have a 5 millimeter margin on your prostate, you got it. And then conventional plan checks, you can verify dose calculation algorithm, dose grid size, CT slice thickness, and dozens of other checks. PlanCheck is a new module in the SunCheck platform from Sun Nuclear. So like ClearCheck, PlanCheck just launches directly as a script in Eclipse. And you can see from the screenshot that it checks a number of different structures and DVH information. So you can verify that your PTV is covered and that your OARs are getting spared as you want. So it displays all the DVH information, compares it against pre-configured templates. It can also look for plan deliverability, plan parameter checks, and contour checks as well. And that plan check is part of this larger SunCheck suite that Sun Nuclear is offering. And I'd be remiss if I didn't mention SunCheck, since as a whole, it is an automated platform that can accommodate a number of hardware and software solutions and kind of tries to provide a solution for everything every part of the radiation oncology workflow. It integrates with hardware like MapCheck or ArcCheck, IC Profiler, things that we have in our clinic, and it collates all that QA data into a single software platform, which I think in itself is a benefit to have it all in one place and not have to mess with a bunch of different spreadsheets or applications. So it's all in one single database. Um, yeah, SunCheck also has a really cool scheduling feature. I know that we all have a lot of different tasks, so having something to kind of remind us of all the things that we need to complete on a monthly and annual basis is extremely helpful. Mobius 3D is a product from Varian. It was purchased a couple years ago in 2018 from Mobius. But yeah, Mobius is probably best known for a 3D comparison of the entire patient volume that uses a gamma analysis, which we're all familiar with from IMRT or VMAT QA, as opposed to just a single point second check. Um, but in addition to that, Mobius 3D can assess target coverage and compares DVH information like some of the other products I mentioned, and it can check for gantry clearance and collisional checks, and kind of serves as a platform as well for Mobius FX if there's anyone that wants to do log file IMRT analysis, it plugs and plays there. So in the treat and post-treat department, there's a new product called QuickCode by Radformation. And QuickCode's an automated billing QA tool that allows you to pull information from ARIA, from the treatment planning system, all relevant data, and it can verify captured charges. So these charges that come from ARIA can be verified against stock or customized templates in QuickCode. And the whole idea here is to reduce errors in radiation billing, and hopefully, after install, everything is done in a consistent, standardized way, and even potentially realize lost revenues. So automation is not a cure-all, and we need to be aware of the limitations of automation. As physicists, we need to use automation responsibly and provide a layer of quality assurance to the products we use. So we need to validate their accuracy and effectiveness prior to clinical implementation. Because automation is often deployed as a systematic solution, verifying the proper functionality prevents large-scale errors from propagating. So, in taking all this back to the reasons for automation, it's clear that by integrating automation to our clinics, we have the ability to create huge value for the patients we serve and the clinics we work in. So, while I've just shown a number of different clinical solutions, none is fit for automating clinical workflow from start to finish. But for now, we're hybrids, and that's okay. But each of these products moves us farther along toward effective error reductions in our clinics, resulting in safer, more efficient radiation therapy. Thank you for attending this talk. I appreciate your attendance. In recognition for some of the slide contributions, I want to thank Research, Murata Medical, Sun Nuclear, and Varian. And again, this is some contact information for me if you do want to reach out. I'm here. Check out the blog for updates from us there, and then please do follow me on LinkedIn and Twitter. And I'll open up the floor for any questions.